Why do we do systematic reviews? Well, there are many reasons. One reason is that often individual studies lack power to detect something which is present. Here's quite a famous example of what's called a cumulative meta-analysis looking at the effects of rofecoxib or Vioxx, a medicine that was recently withdrawn from sale both in the US, Australia and around the world because it was found that this particular drug increased the rate of myocardial infarction. On the left hand side you can see a typical meta-analytic display, also known as a forest plot, and most of the dots are to the right of the line favouring control, i.e. that rofecoxib overall is harmful compared to the comparator. The right hand side is a cumulative meta-analysis whereby the studies were summed prospectively from the beginning, and you can see that from about 2000 there was good evidence that rofecoxib increased the rate of myocardial infarction. If you compare that with the year when rofecoxib was removed from sale, 2005, you can see that for 5 years there was probably inappropriate exposure of patients to this particular agent. If a cumulative meta-analysis was done from the beginning, this may have been avoided. Here's another example of the harmful effects of an intervention. In this case, anti-TNF-alpha antibodies which are used in patients in Australia and around the world for people who have difficult to control rheumatoid arthritis. What you can see here is that there are about 7 randomized controlled trials, that in each case that except one, the Van de Putte study, that there is some suggestion that these particular drugs increase the rate of malignancy, but the confidence intervals cross an odds ratio of 1, that is, that there was no statistically increased rate of malignancy in each of the studies individually, but put together you can see that the meta-analysis, the summary estimator of effect, does not cross 1, i.e. that this intervention increases the rates of malignancy by about the factor of 3 to 4, i.e. a meta-analysis increases the power to detect things, particularly when they're relatively infrequent. Here's another example. We're looking at the effects of antivirals in solid organ transplants by the different drugs that can be used, acyclovir, ganciclovir and valacyclovir. Here the outcome is all-cause mortality. We can see that in no individual study was there evidence that these drugs prevented death. However, you can see that in almost all cases there was a suggestion that these drugs prevented death in these patient groups, but the summary estimator of effect shows that in fact, yes indeed, these drugs do prevent all-cause mortality in organ transplants by about 40%. In addition to power to detect intervention effects, as you know, often interventions work differently in patients. By having broad inclusion criteria, by looking at a range of populations, we can see whether postulated reasons for variations in treatment effect are actually valid. In this case, we're looking at another transplant drug, tacrolimus, versus cyclosporin. Here we're looking at the outcome of acute rejection and graft loss. You can see that overall it appears that tacrolimus compared to cyclosporin reduces the risk of graft loss. But you can also see that there is apparent differences in treatment effects between these particular drugs. In 4 occasions it looks like the intervention is harmful. In 1 occasion the point estimates on the line of no effect, and in the remainder of cases it looks beneficial. A meta-analysis allows you to look at whether hypothesized reasons for the observed variability do explain the observed variability, which we see on the next slide. So in fact, this is a slide looking at dose compared to graft loss on the left and dose compared to diabetes on the right, and that we can see we have a relatively good linear relationship such that the bigger the tacrolimus dose, as evident by a higher trough level, we can see that there is an increased risk of graft loss. So much of the variability that we saw in the previous graph is explained by the dose. Other examples are tamoxifen for early breast cancer. This is a summary of all of the trials looking at the effect of tamoxifen over and above other interventions for early breast cancer. There are 3 groups of trials based on how long tamoxifen is given. And if you look at the summary estimate of effect across the 3 durations, we can see that as the duration of tamoxifen exposure increases, the benefit in terms of reducing recurrence rate from breast cancer increases, i.e. the longer the tamoxifen is given, the greater the benefit. By having a meta-analysis of all studies and that there is variability in terms of duration of exposure allows us to test this hypothesis. Similarly, we can also see whether disease status influences the effect of tamoxifen, and we can see that the treatment effect is greatest in patients who are estrogen receptor positive, and in those who do not have estrogen receptors, then the effect is negligible. So, why do we need systematic reviews? Well, we need systematic reviews because we need reviews. We need reviews to increase the power to detect intervention effects so that we can prevent delay in the introduction of effective therapies, and also to detect potential harms which generally are relatively infrequent. We also want to explore between study differences which better enable us to select an individualized therapy and to cope with the amount of the medical literature. We know, for example, that there are something like 750,000 randomized controlled trials in the health literature. That's far more than any of us can cope with. However, if these randomized trials were summarized in reviews, the literature becomes more accessible and potentially more informative. Well, we need reviews, that's clear. Why do we want systematic reviews? Well, we want to base our policy and practice based upon valid results. We want reviews which have got all of the data rather than a select, probably biased sample of the data to avoid random error and systematic error.